think it's 8 o'clock, so we will go ahead and get started. Good morning, everybody. Stephen, just give me the thumbs up that you can hear me okay. Yep. So before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. So welcome back to Grand Rounds. Hopefully we're beginning to thaw out a little bit. I'm sorry I couldn't be there in person today. So I'm delighted to introduce today's speaker in our new professor series, a continuation of our new professor series. Dr. Stephen Katz, who most of you will know, is a rheumatologist and newly anointed professor of medicine at the University of Alberta. He's served in a variety of leadership roles, and most of you will remember him as our former Core IM program director, which has a massive administrative component to it. But currently is serving as the director and the section chief for the Division of Rheumatology. And he's going to speak today about looking for scholarship and leadership. So I will hand it over to Stephen.
Great. Thank you very much. It was interesting when asked to give this talk what I was going to talk about. As most of us with some imposter syndrome, you think, what is there to actually share? And maybe I will let you decide at the end if there was anything worth sharing. But I think my career path was maybe a little bit different in terms of being in an academic setting. I think a lot of folks, it's scholarly for within a specific research area, within medical education. And I feel my sense is that my path has been a little bit different, although I think just looking at it, maybe it doesn't always seem that way. So I thought I would talk about scholarship opportunities within leadership this morning. In terms of disclosures, I'm just going to advance. I don't have any specific other than say I love rheumatology. Maybe that'll come out a little bit more this morning. But in terms of objectives, demonstrate how to navigate a non-traditional academic path, or at least what I perceive as non-traditional, provide examples on how to find scholarship in leadership, and then task for you is determine if there are any lessons to be learned from my experiences. There may or may not. And again, rheumatology is awesome. Just throwing that out there. What I want to do is really just take you through my story in a semi-linear, but not totally sort of way. But just to start with, some things maybe I didn't recognize at the beginning, and certainly allows, as you reflect back, realize these things. So I realized I like very practical problem solving in something that you can make change, not terribly difficult to do it, that there are solutions to problems, and just kind of finding that path of getting there. I don't mind bashing my head against a wall. I think as a leader, you have to sometimes get used to that. You're going to get lots of no's or a lot of rejection. Obviously, there's lots of that potentially in lots of areas of medicine, but I think in leadership sort of positions, that's not unusual, but you have to be okay with that and take the wins where they are. I like bringing a group to a solution, and that wording is on purpose. So it's not that I necessarily have the solution to bring to a group, but like working with the group to find a solution that's going to work for them. And certainly at the beginning, I didn't know what a leader was, or that's even what I wanted to do. And as I said, I think what appears maybe to be the straight and narrow career path, because if you look at step to step, it was like, oh, okay, that's kind of obvious that he did. In no way was obvious or planned or had any intention, probably, if you would have asked me where I'd be, 10 years ago or more than that. Lots of different definitions of leadership. This one's really simple, but I like it particularly for purposes of today. So the capacity to guide or inspire others and to achieve the desired outcome. Leadership is not about you, it's about the people around you. If you're doing it for power or for title or those sorts of things, it's not worth it. You're not going to be satisfied. And you want to have an end result. Leading just to lead, I don't think is going to get you anywhere, particularly in an academic institution. Having outcome, one, makes everyone happier, but also allows you to have some scholarly output, as I'll show as well. So where did I start? So as most of us started, we were all rheumatology fellows once upon a time, right? But I was a rheumatology fellow with terrible handwriting. That one maybe most of us can relate. And I got really frustrated with how much handwriting I had to do, particularly for prescriptions. So as you know, new rheumatoid arthritis patient, and those who remember old 2E2 and very tiny prescription pads that we used to have to fit in methotrexate, folic acid, sulfasalazine, methotrexate, a prednisone taper. So it probably took like 3 or 4 different ones, and you're writing it out with repeats and all that sort of stuff, and it probably looked terrible and very hard to read. That was really frustrating for me, to the point where I said, okay, what can I do about this? So this is before EMRs, and there's no way I'd be able to create or invent that. But over the 5-day holiday break, I decided I'm going to learn how Excel works and how well what you might be able to do to fix things. So I have no idea what a lot of this is anymore. This was a long time ago, but there was a lot of formulas that I knew very well back then, or learned for their purposes. And ultimately what this led to was this nice little grid, which at the time was the vast majority of rheumatology medications. It's maybe half of what we have now. And you go click, 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 and you get this really nice prescription that you can print off. It prints it off automatically, a second copy that you put in your paper chart, and it was lovely. And so I started using this right away. A number of my colleagues, not all, started using it as well. But the other problem with 2E2 is that every week or two, the computers got wiped. So if you put anything on those desktops, they would go away. So you needed a place to put this information. So thought, well, there's these new things called websites. Now, it sounds crazy, right? But still relatively newer concept that different groups could have websites. And so within the year, built what was the first iteration, and you can see that up in the upper left corner there, of what the Times called EdmontonRheumatology.com, now AlbertaRheumatology.com, with what it looks like down in the lower corner. And really the reason to build it was so we could easily access this Excel file. But if you're building a website, there's lots of other cool things that you could do. So we put information for medications and diseases and that sort of thing. And overall, it's been a success. You know, we have between that and YouTube videos and that, you know, there's over, you know, a couple 100,000 visitors every year throughout the world. However, like I said, there's other things you could do with it. So going back at the same time, working with Anna Oswald, and this was kind of my first kind of scholarly project that I took right from the beginning to say, how can we get internal medicine residents more interested in rheumatology? Because again, I love rheumatology and I don't understand why other people don't love it as much as I do. So we did this survey of internal medicine residents across the country, looking at their confidence and trying to see what made internal medicine resident more confident. And we compared that to 3 other subspecialties as well. And what we found was that if you increase the formal teaching opportunities for rheumatology, not for the others, but only rheumatology, you actually made residents more confident. At least that's what it appeared to be. Well, could we use this website in some sort of way to do that? So shortly after we launched the site, we also launched what called Image of the Month contest. And people who have gone through the program here may remember that, where we'd ask once a month this really simple rheumatology question. It was not trying to trick anyone, little prize at the end of the month, but the idea was for every month, 20 to 40 of the internal medicine residents were getting this little bit of rheumatology exposure that they weren't getting before, because they weren't all necessarily coming through and doing rotations. So that was nice, and I'll show you what the impact potentially of that was in a second. But the other thing that this did, so again, remembering that this started for me, frustration out of writing prescriptions to a website to Image of the Month, put me on the radar for the internal medicine program. Because otherwise, I didn't do my training here. I think I was very much off the radar, and all of a sudden, now I was on the radar and was asked to join one of the committees, and but within a year was asked to become associate internal medicine program director, and my first more formal leadership position. And we'll come back to that in a moment. But again, back to the website just for a sec. Is a website scholarly work? Maybe a little bit, but not like you cannot build a academic career, as far as I can see, what I would tell, using just a website. However, websites generate data if you do it in the right sort of way, and there's lots of potential to take it to that next level. And I think that's really where I've had been to develop some opportunities. So just for some examples here, and probably on the big screen probably shows okay. I don't know how well it does depending on the size of your screen on Zoom, but we've done a number of things. So we developed a video looking at how to teach methotrexate self-injection, and we evaluated that compared to what we normally do and showed we were actually able to decrease the amount of teaching time in our clinic, but still ensure that the quality of the teaching was just as good. We took a next step and said, okay, what other information is out there? Because if we're directing our patients to look at this video, they're going to look at other stuff too. And we, not surprisingly, found, this about 10 plus years ago, that a lot of it was pretty terrible quality information. There's maybe 2 or 3 good videos out there. We repeated that within the last couple of years. Shockingly, actually, YouTube's improved quite a bit. There's actually reasonable information, not as much stuff that you would say, ooh, I don't want to see have my patient take a look at that. We have a functionality on the website called Ask the Rheumatologist, where patients, and we've probably had about 1,000 submissions over time now, will submit their questions. Some of them are not appropriate questions, and some of them are quite good in terms of identifying gaps of information that we don't share on the website. So we were able to publish that data and show kind of where these questions are coming from, what kind of questions we get, and how we're able to answer them. We were able to look at the image of the month and report that and share that with other institutions if that was something that they wanted to look at. We've been able to use the website in the other way as well. So we did a study a number of years ago in our clinics in Edmonton looking at natural health product use across our arthritis population, because it's very common that most of our patients use some sort of natural health product, but not necessarily knowing which one. So we have that data, and then that helped inform us to build a natural health product database on our site, which is evidence-based, showing what works, not very much, and what is safe. But it's probably the largest database like that for arthritis in the world. And so we're able to do it the other way. And then more recently, and we're still just starting to build this, but really exciting, is back to the Ask the Rheumatologist. We were able to just publish some data around ChatGPT and how would that answer our questions compared to how a rheumatologist answers it. And maybe not surprisingly, but disappointingly, what we found is that patients are okay with either, and patients can't tell the difference of who wrote these questions, but certainly the rheumatologist can, and that there's a clear quality difference. So as a next step, maybe this is something that we could build ourselves, so we're not manually answering these questions and patients can get good answers in real time. So lots of different neat possibilities of doing and kind of elevating what's low-level scholarly to something a little bit more. So while going back to the story, so while I'm dipping my toes in core internal medicine, a few other things that I'm working on in rheumatology. So we were, I think, one of the first divisions of the department to establish a central triage system. When I started on, it was kind of this hybrid model, and then we were talking about let's go full in, everyone and all patients are part of triage. We need someone to take that work on. And for some reason, I put my hand up. At the time, I was the most junior of our group and very much did not understand what I was getting myself into to essentially negotiate terms amongst a whole bunch of people that they would all agree to have a triage policy in place. But really educational from a leadership point of view of how to do that. Learned very quickly, you don't do that work at meetings. That's this sort of work much more effective to do behind the scenes and have one-to-one conversations with people. And I still very much distinctly remember literally running from my colleagues' offices back and forth to negotiate on their behalf specific terms to make sure that there was compromise and people would agree. But it meant by the time the meeting happened, that everyone was happy and we didn't have to have those kind of more tense conversations. We were able to get that work done. The other part of triage, which again, coming back to the scholarship piece, is that it wasn't just about policy and procedure, because I think setting up triage isn't difficult. You want to have a way to analyze that what you intend to do is actually what you're doing. And I'm not sure we're all using the abilities that we have currently with eClinician before and Connect Care now to the full extent there. But we've always had analytics on the back end of what we've done. And we've been able to publish that data to show that what we wanted to do is working, and that we're not missing patients that we wouldn't want to miss. Again, really helpful for me personally to be able to have that data from a scholarship point of view. But even further, this started to put me on the map regionally, nationally, to work with colleagues across the country who are doing similar sort of work and be more involved in terms of access to care issues and quality of care issues. And then not only am I able to contribute there, but able to bring ideas back to Edmonton to hopefully continue to improve our system as well. Around the same time as when we were starting with EMRs, worked originally with Dr. Stephanie Keeling in terms of that initial launch, which I'm told, not my words, but the rheumatology launch apparently was the best launch of eClinician at the time. But I think, again, it was because we worked to ensure that buy-in amongst all our colleagues to ensure that everyone was on the same page, everyone was comfortable with what we were getting and what we weren't getting and what we might be able to get. So there was very clear expectations of how to do that work, and we can support each other. But I think the other nice thing from my point of view was that I was now starting to do a bunch of little things in a bunch of different areas and learning that there are ways to kind of crosstalk those skills. And to have knowledge over here that I can now apply over there was actually really powerful, rather than kind of having all my chips in one small area. So triage, as we were converting it over from a database and very paper into eClinician and subsequently Connect Care, to understand what was needed on both sides, what works and what doesn't work, has been really helpful. And I think helps not only me to understand and lead that, but help our group as well. And then with any career, luck is a large portion of it. I think I've shared that as well. But I think kind of the luckiest moment that I had was, again, probably 11 or 12 years ago, where there was this new faculty member in the Faculty of Pharmacy and Pharmaceutical Sciences who contacted us and said, I'm interested in rheumatology. Does anyone want to let me come and do clinic? And again, not knowing anything about this person or how that would go or what that would look like, I said, yeah, okay, that sounds interesting. And now it's that many years later, and we have this fantastic collaboration. We have this, we need a better name. If anyone has a better acronym, that'd be great. But we call it right now a Collaborative Rheumatologist Pharmacist Inflammatory Arthritis Follow-up Clinic. It says what it does. But it is, I highlight of the week for me every week. So Dr. Jill Hall sees patients, does history and physical exam, because we've trained that up, does treat to target for all our patients, which probably we should all do, and maybe we don't do as well as we should. Prescriptions for all the patients, I don't have to worry about that. It's all at all, but also for every patient, they get cardiovascular risk reduction, bone health, vaccination review over a lengthier appointment than I can provide, trying to see all the patients that we have. Because it's so comprehensive, most of the time I'm coming in at the end and saying, you have any questions? And they say, no, everything is dealt with, you go away, which is lovely. But it means the volume of that clinic is increased by 50% than would it be otherwise. So not only are we providing better quality of care, but also access to care as well, which again has fit really well with some of the other ideas and things that I've looked at. And of course, because Dr. Hall is on faculty as well, lots of opportunities for us to just chat and come up with different ideas of projects and papers and that sort of thing that are related to the clinic, but also outside the clinic. So it's been really helpful and productive in that way as well. And of course, while this is a great idea of a clinic, having the data to show that is helpful as well. This is a study that we did looking at patient satisfaction with regards to our clinic, which I very much figured they would like Dr. Hall better than me. So I was putting myself out there a little bit. They did not like me, But clearly very happy to have that collaborative approach, which was great to see, and has in the back of my mind the realization that we need to have this Monday to Friday, 9 to 5 sort of thing. So back to medical education, I had the opportunity for about 11 years to serve different roles as a residency program director. So as I said, first started off as associate program director of internal medicine, then spent a few years in rheumatology, and probably at the time thought that's where I was going to be for a really long time. And then this opportunity for a core internal medicine came up. And I have to say, I wasn't sure or sold if this was really something that I wanted, and really had to think about it because it's a big role. Things were running really well. Anytime you take something on, you want to think, am I going to screw it up? And also, what am I going to contribute? How am I going to not say make things better, but make sure it's my own, that I'm going to own it, that I could make some sort of contribution to the role. So obviously, I came around to thinking that something that I might be interested in, took it on, and very thankful that I did have that experience. But I think in these sorts of roles, certainly learned quite a bit in terms of navigating things and making sure that you find success, not just for you, but for the program. So like I said, want to make sure that I knew at least a sense of what I wanted to do, but not to the point that I had to do that. The first day, okay, we're making all these changes. That first year, particularly for the core program, you're running around with your head cut off, just trying to understand what's going on and really living what was already there, but listening the entire time. And I think in these sorts of roles, it's so critical to listen. You'll hear me say this probably over and over again now, that just trying to understand what all the different groups, particularly a program like core internal medicine, but rheumatology as well, there's a lot of different stakeholders for the program. And you have to recognize that they're all important and they all have to feel like they have a voice to be heard. You need to own the program ultimately. As I said, program was running really well before me. It's running really well now, but you have to make sure you're comfortable with how things are going when you're in it. Make it your own. Make sure that the people around you feel like it's theirs as well, and you're not taking over. And of course, if or when you make change, you want to make sure you find ways to report it. Again, that's that scholarly piece. And I would argue medical education, we probably actually don't do a very good job of this overall. I had the opportunity in my role to be in a chat with lots of other department program directors and program directors elsewhere as well, with really amazing ideas and innovations that I think very easily are publishable and shareable, and we don't do a good job of doing that. I think some of it is because we don't realize in our own sphere that they are shareable or that other groups would benefit from doing them as well. But I think there's such great opportunity to be able to share some of these things a lot better. So some things that I've been able to show or share. We launched, it's actually a year or two before I started as rheumatology program director. There was a National Written Rheumatology in Training exam, still goes on. My involvement ultimately became more against on the analytics side to make sure that programs can understand how their residents were doing compared to other groups and that sort of thing. So we're able to share some of that data. And again, going back to the image of the month that I was showing, talking about before. So we looked at the rate of internal medicine residents across the country choosing to go into a rheumatology fellowship. Didn't matter where they did the fellowship, it just mattered where they came from. So as you can see, 20 years ago, overall, really low interest across the country, but even lower in Alberta. We had one person choose to do it over a 3-year period who came from our program. And then 10 years later, numbers went up across the country, and even more substantially because the number of residents overall in the country have gone up. But you could see that that was even more so at our institution. And in fact, if you added a couple more years of data here, you would actually see that we went from number 2 in the country to number 1. I can't say with causation that that was all image of the month, right? But I like to think that that may have played some sort of role of us doing so well. But it's, I think, helpful for us to see this because it gives us a template in a time right now where interest seems a little lower, which I think is very much a COVID effect, to get that interest back up as well. From a core internal medicine point of view, had an opportunity to look at a few different things. So I know particularly as a new program director, but throughout my time there, CARMS caused me so much anxiety. And not because would we match enough residents, but actually quite the other way around of recognizing the huge impact this has on the individual person applying, right? You literally have the future, their future lives in your hand. And if you get it wrong for something, you know, they really want to come here and you don't rank them well, not because they're not great, but because there's something wrong in your system, that has huge impact. You may never know that, you may never see that, but it is significant. And to be able to say that we do CARMS perfectly, I wish I could say that, but it certainly needs improvement, I think, in lots of programs in the country. So one particular thing that we looked at, we took a year's worth of data to see the influence of applicant and reviewer gender on how we ranked for interviews in particular. And again, you could look at the data in a little bit more detail and maybe make an argument either way, but I would argue that actually I think we did pretty good in that regard. But there's a lot of other work that could be done and looked at to ensure that we're doing as best as we can there. We looked at Vision 2020. Everyone, I think we sold that term lots a few years ago, which was really a big review of the clinical curriculum in the internal medicine program. And one of the things that we introduced was this new system called Night Pool. So for those who aren't familiar, Night Pool, similar to Night Float for GIM, where we have one resident on multiple nights in a row to provide coverage rather than a 1 in 4 schedule, that for our, at the university hospital, where we have inpatient, 4 inpatient subspecialties, then instead of doing 1 in 4, which is what we had always traditionally done, to go to a group night float or night pool, as we call it, system, where you have one resident available for every of the specialties, but if they're not busy, they can help each other out. But it also means the daytime residents, who are now not 1 in 4, are always present on their service. When we tried to introduce this, at the beginning, it was very much, residents were in favor of it, thought it was a good idea. Lots of pushback from services, and again, new idea, how's it going to go? Rightly so. So we needed to make sure we had a mechanism into it to say, is this working or not? And if not, what kind of changes do we need to make? So we did a survey, and it's a little over 6 months into the introduction of Night Pool. And what's interesting is that the results were not necessarily backwards, but more different than you would have expected. So the residents, they were okay with it. There was no problems. They were happy that it should continue. They didn't want to get rid of it. But the staff satisfaction was much higher than certainly I think they would have expected based on conversations we had before introduction, and much higher than what we saw from the residents. And I think that was because of the continuity of daycare, continuity of educational opportunity as well, and the issues around handover, which were brought up because you're introducing more handover. They didn't see that as much of an issue. So took something that, again, we needed to do practically, able to circle back because we needed to practically to make sure what we were doing, but then take it that next step and publish that data as well. And then in these sorts of roles, the other opportunity that you have is to have residents come to you and say, we have this great idea, and for them to start to take on essentially leadership positions. So we had a bunch of residents come forward and say, you know what, we think there is burnout fatigue amongst residents. This is in a post-COVID world. Can we do some study and look at that? So they did, and not surprisingly, the rate of burnout fatigue is exactly the same as it is for any of us as well. But what they did show is that that feeling of burnout changes depending on what rotation they're on, and not the rotation, the subject matter, but how call is done on that rotation. Which then the idea again is very practical to circle back to the program and say, okay, is there something that we can do to balance that out a little bit more? So again, taking something that's really practical, making sure you publish and share that data but has some very practical use as well. And then finally, one of the other things we had to work on, this little thing called CBME. I think most of you might have heard about that. But very early on, we had one resident in particular very interested in CBD, and what we looked at was EPA, the O scores for our first year residents, was really didn't have good, reliable data for our more senior residents at the time. But to see, did the scores change depending on who scored them on their EPA between kind of senior residents, so PGY3s versus subspecialty, fellows versus staff. Results, again, probably not surprising to any of you that the PGY3s are a little bit more generous with their scores than staff were. The question, I think, becomes, as a next potential question, does it matter? Right? And I think that's probably still an ongoing question there. So again, lots of opportunity, small, very specific questions, very practical, that then impact how these things sort of run, but worth sharing out as well, both for the purposes of their own, but also for building an academic career. So now, for the last 8 months, I've taken on the role of divisional director, and still early and again, trying to get my feet wet with it. And lots of different things that we're working on. But purely from, again, a scholarly point of view, I realized there's lots of opportunities and things that we're doing. So as I was chatting with some people before we started, we've had about 400 patients over the last 6 months from NWT sent to us to be seen. That's caused lots of different issues that we need to sort out. But from an opportunity point of view, this is 400 people. There's probably 800 in total, I would guess, who have rheumatic disease in Northwest Territories based on the size of the population. But 400 people who we've never described this population, what they look like. And all of a sudden, we have all that data all in the same place at the same time. That's a great opportunity to start to build, to describe what that looks like and figure out next steps of how to, is there better ways to provide care, or are there certain patterns than that population that we wouldn't necessarily see in our Alberta or Southern Canada population as well. We are currently working on a strategic plan in rheumatology, which seems like everyone these days is working on some sort of strategic plan, very much team-based approach, but also a scholarly approach. So instead of having kind of traditional strategic planners, we actually have a PhD implementation scientist working with us on this and leading the project with us, which means that this is things that we hope to be able to publish in terms of results and outcomes and process along the way as well. I think I've shared, and I have a passion for multidisciplinary care and looking how that can impact quality and access to care. And I think that's relatively common across medicine, that these sorts of opportunities are there, but really not yet in rheumatology, both locally and really just starting across Canada. And I think that's something which I hope we can be leaders on, but to ensure that as we do that, similar to that clinic that I run with Dr. Hall, that we're ensuring we're looking at data and being able to report back and show that what we're doing is having the impact that we want it to have. There's lots of opportunity for technology integration. Right now, we spend probably 500 to 1,000 hours every year as a group doing just triaging patients. There must be a better way, because if we aren't spending that time triaging them, we can actually see them, which would be much better in terms of access to care. So we're looking at ways to integrate technology to do that. And maybe not as scholarly, but certainly to me important, which is why I'm putting it here, convince the world, convince you that what rheumatology does is not just arthritis. And what I mean by that is not that we see other diseases like vasculitis and organ-threatening lupus, but that even things like osteoarthritis, rheumatoid arthritis have huge impact on our overall healthcare system. And that if we were able to provide better access, better care, and have better resources, it actually is going to impact all of us. So while I know these days with the healthcare system the way it is, this is probably how we all feel. I would love over time to be able to convince everyone that it probably should look a little bit more like this. The amount of ER visits for those with arthritis is 7 to 8% in this province. That's a huge number. We know the folks with arthritis are admitted to hospital at a significantly greater rate than those who don't have arthritis. We know biologic costs are the #1 cost year over year over year for the province, for anywhere in Canada. If you're able to reallocate those resources for everyone else, we've helped everyone, not only those with some sort of rheumatic disease. So just to finish up quickly, in my divisional director role, I feel I need to promote my colleagues. So I am going to do that and share that you should all come back in April, where we have essentially a whole month of rheumatology for you with Drs. Maximovich and Dr. Yee, and then restarting our annual Percy Russell lecture with Dr. Hani Agavalawi, and we'll tell you more about that as time gets closer. To finish up, though, just a few thoughts. So you don't know if you like it if you don't try. Sounds very much like what I tell my kids, but I think there's something to that for all of us, especially when it comes to leadership, because there's not some great opportunity to necessarily get reimbursed or integrated into your practice easily. You really need to take a little bit of a leap of faith, and you're doing it because it's going to provide some sort of self-satisfaction in terms of that process. But I find as I've started to try to recruit potential future leaders, that hearing more and more often than yes these days. And I think part of that is, in the fee-for-service world, we don't compensate these roles particularly well, so that's an easy no. And in the salaried world, we have these wonderful ISAs that come across as very strict in terms of the types of things that we can do. But actually, I think in both these things, there's lots of wiggle room. And I'm not suggesting that people should take on more than their time allows, but if it's something that's going to make you happy, that is payment of itself, and we shouldn't forget that too. And that's going to hopefully make the system overall a better place. In terms of leadership, remember that being a leader is being an advocate for your group. It's a responsibility, it's a privilege, and that you really are helping all these other people. That is why you're there, not really shouldn't be for any other reason. Own your mistakes. I remember before I came on as core internal medicine program director that we were doing external reviews, and I was asked, even though I wasn't on the IMRPC, I got to sit in on the meeting of RPC where the external reviewers that were there, and a comment was made of, and he probably doesn't know this, so if he's listening now he knows, Dr. Rolfson, that if he hasn't, prepared something like expected at RPC or something like that, he owns it, says it right away, and then everything moves on and it gets done eventually. And I thought that was really powerful, and something that I hope that I try to integrate in terms of what I do as well, rather than trying to shift blame or anything else. And not only own mistakes of your own, but of your team, right? Ultimately, you are responsible, and even if it's someone else, it's on you to own it, and that's going to just make everyone happier and a better place to be. Even as a leader, imposter syndrome is normal. In fact, I think, at least this to a little extent, is healthy, because it makes sure that you know that not all your ideas are going to be fantastic. I often would tell the residents that I may have some crazy idea. If you think it's terrible, full stop. It's done. So that is all good. And as I said before, make sure you listen. You are only as good as the people around you. Your team is not complaining. They are inspiring problems worth solving. And you have to remember they're coming to you with their concerns with real purpose. You don't want to ignore that. Your team is going to inspire solutions. I think I get a lot of credit for solutions that have come up over the years, which are not my solutions. I've just had an opportunity to take the problem, take the solution, and bring them together. And your team really should inspire you to do your work. That is why you're there, and that should bring you happiness. But hopefully in your position, you're bringing happiness as well. I think, we talk a lot about wellness and work-life balance. And I think particularly here, more than, being able to provide a meal or whatever sort of wellness opportunity, providing folks the tools to do their job the best they can is going to bring more wellness and resolve some of these other issues. And I know that's a big struggle in the system as it is now, but I think if we're able to work towards that, or at least show people that we're trying to work towards that, that makes a huge difference. So this is where I've been so far, and we'll see where we end up going. I can't not forget to thank the people who inspire me all the time, and that's our fantastic, amazing rheumatology team. All smiling, I think. But thank you very much. And that's all I have to share for this morning.
Thanks, Stephen. That was outstanding. What a great picture. I hope you have that somewhere on your floor.
Yeah.
It's really cool. So I'm just gonna kick it off by asking, and obviously I have my opinions about this and my thoughts, but in a lot of situations, I think people either don't step up or have that imposter syndrome because they don't think they can do it. And so, what are your thoughts about leadership training and sort of, developing tools to do some of the things that you talked about and get some of those skills? Do you want to comment on that at all?
Yeah, I think to a certain extent, it's probably hard for me to comment because I didn't have those opportunities. So it's hard to reflect back and say what would have that changed or looked like. I think a lot of it for me has been to look around and look at other leaders and see, what do they do well, what do they not do well, and then you try to integrate that into yourself. But if there is a better approach where we're teaching that overtly, I think that's great opportunity. I think it's often chicken and egg, right? Where if you don't know if you're going to be a leader, are you going to take that opportunity to get the training? And now if you're a leader, do you take the opportunity to get the training because you're already in the position, depending on at what point you're in that position? I think for kind of that junior leader position, it's perfect though.
Yeah, and I guess part two of that would be around mentorship and sponsorship and all of that. Any thoughts with regards to how important that is in developing?
Absolutely, and trying to have those discussions with people early on, and not necessarily to convince them that they need to go for that top position of leadership, but to put them in positions where at least you think that they'll succeed, and to slowly build that up, I think makes a huge difference in terms of that future potential.
Yeah. I'll just read this chat from my friend, Dr. Hagan. He says he is the medical advisor for the Northwest Territories Department of Health and Social Services. He regularly attends internal medicine grand rounds. Medical community up here has been hugely impressed with the organized approach you and your colleagues have taken to facilitate access to rheumatological care for patients across the territory, despite challenges in manpower, the specialty in Alberta. Thanks so much for this. Yeah. So it hasn't gone unnoticed.
We appreciate it, but I'll tell you, we would much rather provide that care back where the patients are in Northwest Territories. We would love that opportunity to return care there.
Yeah. So Stephen, obviously I can't see the room. I'll give you a chance to look across and see if there's any questions in the room.
Stephen, I work with lots of program directors, who are feeling kind of like one nostril above the surface, trying to just like keep the lights on and manage the day-to-day tasks of their leadership roles. And I'm really impressed how you've managed to leverage those roles into scholarly activity. I noticed many of these papers are collaborative with learners. What tips do you have for new or existing program directors to be able to take that pause to make it scholarly? Because it is a deliberate choice.
Yeah, and it is finding the time, which can be a challenge. I mean, fortunately, in the back of my mind, I also recognize in an academic institution, we're afforded a little bit of that research time, and so if I'm able to leverage one off the other, that probably creates some efficiency for me rather than needing to work in something totally different. And so it's trying to find the efficiencies again of all the different things that I do. How do you combine them together to use them all as one? But also to recognize as much as possible, you have a team around you, right? In rheumatology, we instituted chief residents and gave them lots of responsibility, which I think has an educational role, but then also helps. You have to realize we have wonderful MEPCs who can do a lot of work in internal medicine. One of the very first things I did was bring on an additional associate internal medicine program director to help share that work. But also, when you share the work, you have to let them do the work and take that responsibility and trust them. Because the moment you micromanage, you're going to run out of time. And it's hard for all of us because I think most of us are type A and we want to micromanage. And some of that was challenging at the very beginning for me to let go of, but it would not have been possible to do anything but drown if I wouldn't have.
Any other questions in the room? Yeah.
Dr. Keeling.
Well, you've done a lot for us and we're really grateful. Wonderful talk. I'm just wondering if you had access to the resources that you needed, what's your vision for the division of rheumatology within the department in the next 10 years? Feedback.
So Dr. Keeling asked, what's my vision for the division? And I think, as I probably said, I was probably in this room 10 months ago, that it's not necessarily my vision, but it's our vision. As the rheumatologists know in this room, we're working on a strategic plan right now, which is almost complete, but I think very much trying to integrate all the different things that we do and to provide better multidisciplinary services because, we could easily, as you know, hire 10 rheumatologists for Edmonton to address the capacity issues that we're having. And we know the moment we hire 10, we'll have 10 of us be retiring because it's going to take us that long to recruit. The numbers aren't there. So it's looking at new different models of care and making sure that as we do that, we're collecting data at the same time. So not only we're providing better care, better access to care, but also making sure that that's very academic and scholarly at the same time. PJ?
Thank you for your talk, Stephen. It's a bit of a longer comment first, but there is a question. I had an interesting run with John Meddings, our former department chair, who had been about 5 years ago. He's the dean in Calgary. And we were just talking about leadership roles, and he immediately just said, BJ, everyone tells you to say no to protect yourself. He said, I always say yes. And it was sort of a bit interesting because you're like, that's not what people tell you to do. But I use that to say, part of what you said was, we do need to say yes, despite the imposter syndrome. But there's probably got to be times through your career you had to say no. Just for the audience, what were the things that you thought about and factored in with those kind of decisions?
I think VJ's comment was, I've suggested say yes more often to opportunities, but there must be times when I've said no. When are those times and what kind of considerations? So I mean, ultimately, it's about what am I going to enjoy? What's going to bring me happiness? And I really think that's important to guide you. I find even sometimes with our junior faculty that sometimes I've heard from them where they're being pushed to do one thing rather than what they really want to do. And I try to encourage them, do what you want to do because you're going to be happier, which means everyone around you is going to be happy with the work and that sort of thing. So in one sense, maybe I was lucky in that I was going to be happy with a bunch of different things. But I think a lot of us have more than one interest and would be happy with those different things. And it's trying to you want to make, again, not to overwhelm ourselves, but make sure that we can balance that out. And as long as we can find a way, and again, not to overstretch to make that work. And usually we can, right? I mean, there's a point where we get too busy, but it's amazing how efficient we can be when we are busier as well.
And I'll just come back to, if you don't try it, you won't know.
Exactly.
Any other questions in the room? I don't see anything in the chat, so. Okay.
Nope.
All right. Well, with that, I guess we'll give everybody 10 minutes back in their day. I really want to take this opportunity to thank Stephen. I think that amazing department like ours doesn't run without leaders like Stephen, and he really has stepped up in many situations. And you can obviously just based on his passion, hear his sort of love for the institution and the importance of serving in these roles, and that there is scholarship that is associated with it. So thank you, Stephen. Just a couple of announcements. Number one is that we are going to, speaking of strategic plans, we are going to be updating our website for folks to sign up for those various tasks. So keep an eye out for that. I'm hoping by next week we'll have that done. And the second thing is that I believe Andrea's team and Dr. Tim Chan are still looking for individuals to volunteer for our upcoming medical jeopardy rounds. It's always fun, but we do need volunteers. So please just contact her directly or myself or what have you. And with that, I will just wish you all a wonderful weekend and stay warm. Take care.